Medical Center of Navicent Health in Macon. Dr. Jarrard completed a fellowship in advanced gastrointestinal minimally invasive surgery and bariatric surgery at St. Luke's Hospital of Kansas City. He is a general and bariatric surgeon with South Georgia Surgical Associates here in Thomasville. Please help me welcome Dr. Jarrard.
Thank you, guys. Thanks for coming out this afternoon. Hopefully this will be educational and concise. Please let me know if you have questions. So the agenda tonight is basically to tell you what is a hernia, how and why does it happen, what should we do about it, what are the options to you if you have a hernia. So there's more than 1 million abdominal wall repairs performed in the U.S. each year, and I think this is actually data from 10 or so years ago, and it's even more than this now. So it's one of the more common surgeries that we perform as general surgeons. What is a hernia? So this pointer works here. So here being your abdominal wall, a defect in this abdominal wall, and your abdominal wall consists of multiple layers. You have skin, you have a fatty layer, and then you have this muscular layer. It's the muscular layer that has a hole in it that causes a hernia. So your bowel or whatever is coming out is still covered by a layer of fat and skin, but that's why it's kind of soft and squishy, and it can kind of come and go and get larger and get smaller. So that is a hernia. What causes hernias, to be honest, most commonly is a question mark. It's idiopathic, or it kind of comes on its own. A lot of people are born with hernias. It's very common to have a groin hernia and even a belly button hernia that you're born with, and you just never notice it until it starts getting larger as you're an adult. You gain weight. You have pregnancy, so your abdomen distends, or for a number of other reasons. Prior abdominal surgeries is a specific type of hernia called an incisional hernia, and this can occur after any violation of your abdominal wall for surgery. We try to close that back the best we can, but sometimes it opens back up anyway, and that would be called an incisional hernia. Weak connective tissue. So there's now some new research out there showing that there may be a genetic component to this. Some people are referred to as hernia formers. They've had hernias on both sides and in their belly button, and they have a hiatal hernia, and they have different types of hernia. That kind of patient, if you open them up and do surgery on them, you can kind of bet that they may develop another hernia. And it's just genetically weakened connective tissue and healing tissue. So there may be a genetic component to it as well. Any surgery that you had in wound infection significantly increases your risk of getting a hernia. Diabetes and smoking are also very, very big contributors to poor wound healing. So what are the symptoms of a hernia? So the common symptoms in the groin or abdomen that may indicate that you have a hernia: pain or a bulge. Now there's lots of things that cause aches and pains, and just because you have pain in a certain area doesn't necessarily mean you have a hernia, but it could be an early sign. If you don't really have a bulge or anything actually coming out, it's worth looking into. So how do you diagnose a hernia? By far the most common way to diagnose a hernia is on physical exam. So see a surgeon, see someone who actually sees hernias all the time, and knows how to examine for a hernia if you're concerned that you have one. For those patients that maybe has pain or has symptoms of maybe they have a hernia but we can't actually feel one, there's different imaging modalities we can do, primarily CAT scan and ultrasound, depending on where we think the hernia is. MRIs are also very good. If the CAT scan didn't really show anything, it can pick up on tendon injuries and things like that mimic hernias that wouldn't necessarily show up on a CAT scan and usually don't need any type of surgery. So what are your options for a hernia? Watching and waiting is an option. Wearing a truss or a belt just for support is an option. Those are usually not good long-term options. And then surgery, of course, is why I'm up here talking about it. So there's been lots of studies on this, and there's different types of hernias, and there's been different types of studies on different types of hernias. Most commonly, I hear about inguinal hernias or groin hernias. I hear lots of people argue, well, there's been lots of studies that show it's safe just to watch and wait. And that's true. There was a study released about 7 or 8 years ago, and I was still in training, and it compared 10 or 12,000 people. It was a huge study. Half of them got surgery for the hernia, the other half just watched and they didn't get any surgery. Well, about 80% of the people who did not get surgery ended up getting surgery within the next 5 years because it became more and more painful. So is it safe to watch and wait? Yes. There's about a 1% chance per year that your bowels can get stuck on your hernia, and that can cause major problems. 1% is not a lot. 1% per year for 10 years or so, you're going to start developing symptoms from them. So is it safe to watch and wait? Yes. Most people, 70 to 80% of people that are watching and waiting will develop symptoms at some point and require surgery. Most of my patients that wear a truss or a belt, it's typically because they're symptomatic from their hernia, they need some support from it, and they're wearing this leading up in anticipation of surgery. Very few people wear a truss long term for years and years and are satisfied with that. So we'll talk more about surgery. So the basic concept behind this surgery is to close your abdominal wall back so that that hole is gone, nothing can come back out. That's the basis of it. There's multiple avenues to get this accomplished, to close your abdominal wall. There's traditional open surgery, then there's minimally invasive techniques, and that's what we're going to talk a little bit more about. So open surgery is just what it sounds like. You get a big incision right on top of your hernia that we can see. We clear things out, get everything where it's supposed to lie, close your abdominal wall back up. Most people use mesh. I know mesh is probably lawyers' favorite thing to discuss. The bottom line is if you don't use mesh, you probably have a 50 or 60% chance of the hernia coming back. If you use mesh, it's more like 10 to 15%. So you can imagine why we like to use mesh. There's hundreds of types of mesh. There's tons and tons out there. There's always new iterations or new changes in mesh and technology. I honestly tend to be a fan of stuff that's been around for 50 or 60 years and has never been sued and it's never had a problem. So that's the kind of mesh that I use. But there's different types of mesh and different indications to use them. There's different places to put mesh. You can put mesh in the abdomen and close the wall over it. You can separate the wall in layers and almost sandwich the mesh in between layers. Or you can close and put mesh on top. And there's different reasons to do different types. So back to open repair, potential benefits. So honestly, this remains the standard of care because most people are trained or everybody is trained in open hernia repair. And it takes additional or separate training or time to learn some of the minimally invasive approaches. So the gold standard of care is still open hernia surgery. Upfront costs are often less, and I won't argue this at all. The cost of your surgery is likely going to be less for an open repair than it is for a minimally invasive repair. However, there's been tons of research that's confirmed the global costs or the overall and long-term costs are much cheaper because your hospital stays, a little bit longer for an open repair, your return to work is a little bit longer, your risk of complications and wound infections are a little bit higher. So the costs of all those things put together tend to make open repair a more expensive option long term if you were to have any of those issues. Does that make sense? Surgery time is often less. I think most of us would agree that we could do an open repair a lot faster than a minimally invasive repair. What does that mean for you? You're asleep the whole time, so it doesn't make much of a difference. And this may be necessary for extremely large hernias. So I love laparoscopic surgery. I love when I can putting a camera in and getting the job done that way without making big cuts. But if you have a giant hernia, all of your guts are out, pardon my French, there's nowhere to put a camera. There's nowhere to operate. So in those scenarios, you have to have an open operation. So there are indications where you just have to do it this way. What are the risks? I kind of covered this already. There's an increased risk of postoperative pain, wound complications. There's a slower return to work for open hernias, and may miss concomitant smaller hernias. What that means is when I do a minimally invasive approach, 10 to 20% of the time, I'll look at the hernia that I came to fix, and I'll see one or two smaller hernias above or below that bigger hernia. that may or may not become a problem in the future, but this allows me to address them all at the same time. You can't really see all those with an open approach. You're only seeing right where you make your incision. So laparoscopic repair. So this is just putting the small poke holes and repairing it this way. So potential benefits is a faster return to work. You have smaller incisions. The pain is typically less. Again, able to identify smaller hernias that you weren't anticipating, fewer wound complications. The risks, most people that do laparoscopic hernia repairs don't actually close the defect. They just put mesh and span or bridge the defect with mesh to keep bowel from going back in there. So there's been some new research out there that shows a benefit to actually closing your abdominal wall up. This is one negative to a traditional laparoscopic repair, as you're usually not closing that defect. You're just, bridging the gap with a piece of mesh. The fixation tacks or sutures, so that mesh has to be fixated. Sometimes there's tacks or sutures that are used or can be pretty painful. I've even heard patients say that that's more painful than just getting a big incision. I've never had either, so I couldn't comment on that. And the risk of a hernia recurring may be higher with a laparoscopic approach than a traditional open hernia repair. Now moving on to robotic-assisted repairs. So this is technically laparoscopic surgery. We just use a robotic platform that basically connects the robot to the instrument ports that you put in place, and the surgeon is basically controlling the robot. So the robot is not autonomous. It's not a robot operating on you. It's just a machine that allows more fine-tuned manipulation of tissue, suturing, allows the surgeon to do a little bit more through smaller incisions. So most of my robotic repairs just require 3 8-millimeter incisions out laterally on the left side, so there's no midline incisions, there's nothing on the middle, they're all out laterally. Potential benefits, so the hernia is closed with mesh through smaller incisions and basically has most of the benefits of a laparoscopic repair. However, I always close the defect robotically. The suturing that you can do robotically is almost impossible to do laparoscopically, so that's why we're able to get that defect closed and use a good piece of mesh to repair or reinforce the repair. More often than not, I keep the mesh out of the abdomen. I'll separate a tissue layer down, repair the hernia, put mesh in there, and then close that tissue layer up. I think there's fewer adhesions, or your bowel doesn't stick to the mesh if it can't get to it, so I try to keep all of my mesh, if I can, out of the abdomen for that reason. Larger hernias, this may increase operative time, and we kind of talked about the big giant hernias that you may or may not have seen somebody walking around with. I can do these robotically. They take a little bit longer to do, probably twice as long as a traditional open repair. Hospital stays a lot less, so that's how I justify it. Higher upfront costs. There's no specific cost for the robot. It's just a laparoscopic repair. So if you get a hospital bill for a robotic procedure, it's the same cost as a laparoscopic repair, which again may be more expensive upfront for the surgery than an open repair. But if you factor in the decreased wound complications, infection rates, return to work, pain, et cetera, the global cost is thought to be less. So what is robotic-assisted surgery? So if you decide that this is right for you, come see me, we'll talk more about it, and I can show you pictures and really, get into some more detail about it. So the actual incision size is 8 millimeters, which is, just over 1/3 of an inch. It's pretty small. We put a small incision in, put the camera in, and use that camera to guide where we put the other incisions. Again, I use traditionally 3 small incisions on the left side. Once I get my trocars or instrument ports in, I'll connect the robot to that. I will go to the console and operate the robot to fix the hernia. So this is just a quick review of some published studies that suggest some of the benefits of robotic repair. So patients who had an inguinal hernia repair via a robotic system had a lower rate of wound complications and after surgery, from the time they left the hospital through the first 30 days after surgery, compared to patients who had an open surgery. Patients who had a ventral hernia repair, meaning the hernia up here, had to see their doctor less frequently, had less complications where we had to go to the hospital or see your doctor after surgery compared to the open repair. Again, some ventral hernias may require more complex repair, where we would have to separate the abdominal wall muscles to get everything to come together. Patients who get that done robotically have far less complications, a shorter hospital stay, a faster return to work, getting it done on the robotic platform as opposed to getting the big incision. Patients who underwent a non-complex, so just a basic routine 3-incision ventral hernia, stayed in the hospital less time than patients who had a laparoscopic repair. So this isn't comparing minimally invasive to open. This study was showing that there's, the robotic platform is better than traditional laparoscopic surgery. So every surgery has its risks. Some of the potential risk for hernia repair. There are specific risks based on the type of repair that you get and the type of hernia that you have, including ventral, incisional, and umbilical and inguinals, and we've kind of talked about each of those. Recurrence is sort of the big one. That's kind of what we have to talk about. We judge how good a hernia repair is based on your recurrence rates. So again, big abdominal wall hernias or ventral hernias have a very high recurrence rate without using mesh. If you do the best repair known to man and use mesh, we can get your recurrence rate down to 10% or so, maybe up to 15, depending on what else you have going on. But that's not zero. That's not, I hope one day we could do better, but it's far better than the 50 to 60%. Inguinal hernias or the groin hernias, the recurrence rate ranges between 2 and 3% in the literature, so a lot less, a lot lower. Since we're going into the abdomen, there's always a theoretical risk to the bowel or intestine infection of the mesh or urinary retention. Bowel injuries and mesh infections are extraordinarily rare. I've had one in my career, and it was unfortunately in a patient who had chronic abdominal wall infections related to a gastric band that she had, years and years and years ago. But other than that, without any existing infection, the risk of getting your mesh infected is extremely low. Urinary retention, you actually see this commonly in the older male population, specifically anybody with a large prostate. It may be difficult to urinate right after the surgery. That's not that uncommon. Anybody over 60 that I operate on, I make sure they pee before they go home. That way you're not, stuck at midnight, not able to pee and have to go to the ER. So everybody has to pee before going home, and I try to avoid that issue. Specifically for groin hernia repairs in males, there's always the risk of not testicular injury per se, but the vessels and the cord structures that go to the testicle can be injured. The hernia sac or contents lay right on top of the spermatic cord, so injuring that is always a possibility. It's actually extremely rare to do that. There are lots of small veins and small blood vessels that go to the testicles that can theoretically be injured. More often than not, that can cause prolonged pain, a little bit of swelling early on, but it's short-lived and it goes away on its own. The risk of nerve injury, maybe someone who's had a hernia repaired before, now they have chronic pain. The chances of that happening through a laparoscopic or a minimally invasive approach is far less than with an open repair. I actually have several patients that have been sent to me for that exact same problem. What I try to do if their hernia comes back is I'll go in from below and do a minimally invasive repair and just cut their nerve at the time if I can. So it's a common problem, nerve damage and chronic pain after an open hernia with mesh. See it a lot less often through minimally invasive approaches. Some of the questions that you can consider asking your doctor or me if you come to see me with concerns. Basically, what are the options that are available to you? I talk about open repairs and laparoscopic repairs and robotic repairs, and what I really stress to patients is I hope that you'll trust that I'll help you make the best decision. Not everybody's a robotic candidate or a laparoscopic candidate. Not everybody is a candidate to have your hernia repaired at all. So a lot of questions that are difficult to answer tonight and, in a 30-minute presentation. So I encourage you, if you think you have a hernia or would like to get it repaired, please come see me, one of my partners, and we can talk more about it. Generally, patients that are morbidly obese, the recurrence rate from ventral hernias are so high it's almost not worth doing. So most of my patients, I try to get into a weight loss program or get you losing weight. For the morbidly obese patients, I even sometimes I'm a bariatric surgeon, so sometimes I do weight loss surgery prior to fixing your hernia, allow you to lose 100 pounds or so, and then I'll go back later and fix your hernia. And those patients have so much better outcomes by doing a 2-stage repair. I love to operate, but I try to be safe about it. So if I tell you that this or that's not a good idea for you, just trust that I'm trying to do it to be safe. Other questions to ask: what's the difference between everything that I just talked about if you didn't catch everything? How long does the surgery take? Depends on the type of surgery. If you've had previous surgeries, if you have scar tissue, a lot of factors that go into that. Most inguinal hernia repairs are done in less than an hour. Ventral hernia repairs, an hour to an hour and a half. If you get the big giant hernia that you want me to fix and split the muscle layers apart, that's at least a 4-hour operation. Most patients go home the same day after hernia repairs. The only ones I keep are the big giant hernias or larger ventral hernias. Is typically an overnight stay. And even the ones that get the component separation for the repairs of the 10 and 12 centimeter hernias, I think 90% of mine have gone home the following day so far without drains, which I think is pretty good. When can I return to normal physical activity? My general rule is 3 weeks for a groin hernia and 6 weeks for a ventral hernia. Now, you're not recovering that whole time. You're not in pain and you're not miserable that whole time. Generally, you're doing well after your first few days, and it's actually easier to go misbehave because you're not hurting as much and you think, hey, I'll just go back to work. Patients do that and typically regret it. Going back to work too soon, straining too soon, doing things too soon just increases your risk of that hernia coming back. So in general, 3 weeks for a groin hernia, 6 weeks for ventral hernias. Any questions? Yes.
What about athletes? They have trouble going back to playing, or the doctor said that they need more time.
Right.
Yeah.
Yeah. That's a tough area. An athlete with a hernia, generally the same course of recovery of a few days being sore. I tell them no strenuous stuff for a few weeks. Well, when I tell that to an 80-year-old lady, take it easy for a few weeks, and then get back into your normal activities. That's a little bit different from a 22-year-old football player that after 3 weeks he's going back on the squat bench, and working out. That's a little bit tougher, and when I tell most of those patients, 3 to 4 weeks of nothing, gradually ease back into it. But yeah, I mean they're at probably a higher risk population of recurring a hernia if they return back to their sports too soon. Most of those guys are young and healthy, have great strong tissue, so the tissue comes together and heals a little bit better, a little bit faster, and I think can get a more durable repair in a young athlete. So. I don't necessarily change my recommendations based on anything. Yeah. Oh, that's very true. I think a minimally invasive approach to the hernia is great for that reason. I myself have had an open hernia repair, and I was 15 or so, and I was down and out for several days. I mean, it hurt and it was sore, and even when I gradually got back into things, it was pretty rough. Unfortunately, I haven't had a minimally invasive repair to compare that to. I have had a few patients that have had an open. I later did a minimally invasive repair, and they just said it was night and day. The difference, the return to work and activities is so much faster. So, yeah, after 3 weeks, they should be good to go. Any other questions? Yeah.
Your patients that you've done your bariatric and dissertation doing the hernia repair, insurance pay for bariatric at that point because of the hernia?
So, Good question. Bariatric surgery is tricky. Insurance companies some are on board and some aren't on board. It largely depends on what type of insurance you have, and if you just are just curious, call my office, and my nurse is an expert. Like, she's got them all memorized. I don't. I know CMS, Medicare, Medicaid does cover it. Archbold insurance does cover bariatrics. Blue Cross Blue Shield is iffy. Some of the Blue Cross Blue Shield plans or Pathway X don't. It depends on the type of insurance you have. So in general, bariatric surgery is only covered if you meet a certain BMI limit and you have comorbidities, meaning high blood pressure or diabetes or cholesterol. We can consider a hernia one of those comorbidities, but I can't get you automatically approved just because you have a hernia. Does that answer your question? Yeah.
You said some people born with hernia. Is there an age limit to knowing that you have, or you can still have one?
So in general, there's a few types of growing hernias. There's direct and indirect hernias. Direct hernias are just a direct tear through your abdominal wall. That is not something you're born with. Indirect hernias are a little bit tougher. Indirect hernias is basically you have a canal where your testicle descends into your scrotum during development. If that canal doesn't close down all the way, over the time as you get older, you can have a defect through there. Now, if you're 60 and you have an indirect hernia, it's hard to prove that now you've had it your entire life. Sort of some conjecture. Typically, belly button hernias that happen inside directly in your belly button. Your belly button didn't close all the way during development, and it's just been small. And as you get older and get bigger, it can gradually grow in size. So most belly button hernias are congenital. Not all of them, but most. Typically, hernias elsewhere are something you develop with time. Does that make sense? Yeah.
Is it common to mistake hernia pain for something else, like maybe appendicitis or anything, or vice versa?
Yeah. So pain in itself is a very, very common sign or symptom. Depending on where the pain is, how your pain presents, how long you've had it, it can sound more or less like a hernia. Appendicitis, I mean, it hurts for a day or two, then it ruptures and you get sick as a dog. So anybody who has pain for a few weeks, it's not appendicitis, or diverticulitis. Anything infectious usually progresses pretty quick until you're sick. You can have joint pain or hip pain. If you have arthritis, I have lots of patients with hip pain that they want me to see them for a hernia. I can't feel a hernia on an exam. Typically, the pain's more lateral. So pain closer in the groin that you have that's more chronic or long-standing can be a hernia. If I can't feel one on an exam, I usually get a CAT scan or an ultrasound. One of the more common things that confused with a hernia is called a sports hernia, and that's more of a tear or inflammation of the medial tendons. But there's no actual hernia defect there. It's a misnomer. It's not a true hernia. So young athletes with pain, really bad pain here, and if I can't find a hernia on an exam, I usually get an MRI and say, you have a sports hernia, and I'll give them NSAIDs and physical therapy and try to get through it without surgery.
What's the difference in
Hiatal hernia is a little bit different. So your chest cavity and your abdominal cavity is separated by two dome-shaped muscles, your diaphragm. Right in the middle of those muscles is your hiatus, and that's just a normal hole where your esophagus, aorta, all your chest structures go into your belly. Well, over time, for whatever reason, that hole can get bigger and bigger, and your stomach can start sliding up into it. You can't see that. You can't feel it. I have people all the time that says, well, I got something right here. I think I have a hiatal hernia. Well, that's not a hiatal hernia. It's deep. It's on the inside. You can't see or feel it. It's just your stomach sliding up into your chest. I love to fix those too, so come see me. Any other questions?
My son was born with an umbilical hernia.
Yeah.
He's 49 and a half. And has ever been done about it. Do you think he can live forever with it?
It's possible. That kind of goes back to the watch and wait thing. Generally, what I tell people with belly button hernias, I got a belly button hernia. It's tiny. It doesn't bother me at all. I can kind of tell that it's there. Generally, for those patients that just don't want surgery, or they're doing fine, or they've had it for 40 years, it's hard to talk them into doing something about it, and I don't necessarily try to. So just educate them. If your hernia ever gets suddenly bigger, hard, painful, seek medical attention right away, because your bowel could be stuck in it. The chance of that happening is pretty rare, but you at least need to know what to look out for. Other questions? All right, yeah.
This individual had previous open hernia. Would be a good candidate for robotic?
Yeah, absolutely. Yeah, when minimally invasive approaches first came out, it was a learning curve for everybody because we didn't have dedicated fellowships or training years for this. So it was generally general surgeons trying to pick up a new technology on the fly. And their initial guidelines said that the only reason to ever do this is if you've had an open hernia before, it's just easier to go through a different tissue plane, or if you have hernias on both sides, so you can do it through less incisions. Well, as we got better and better at it and the benefits became more apparent and the risk became less, I do almost exclusively robotic hernias on everybody, with the exception of the guy who comes into the ER with a hernia this big with dead bowel in it. I don't try. But I almost do robotic repairs exclusively. I do a laparoscopic repair occasionally. It's pretty rare that I do open repairs except for my kids. Kids I do open repairs on because I don't use mesh. So there's really no need to do a laparoscopic repair without mesh. But yeah, as a general rule, if you've been through a plane before, it's kind of hard to go through again, so it's an ideal candidate to go a different direction. Yeah. I had some videos. I had videos of repairs and things like that. I didn't have time to get it all together and for this presentation. And I suggested that to my wife, and she kind of turns her nose up and says it's gross and didn't want to see it anyway. So maybe I could show you in my office if you're interested. So everybody have a good idea of what a hernia is, and this is a common question. It's not just pain, it's an actual defect that fat or intestine can come through. The dangers of it being if that intestine gets stuck, the blood supply can get cut off, it can cause problems. The most common problem is pain or discomfort. Generally, if you have a hernia and you're having pain or discomfort, it's recommended that you get it repaired. The only patients I would recommend watching and waiting is if you were completely without symptoms and you just don't want to have surgery. Yeah.
Is it good to have a hernia removed, being overweight, with it coming back faster?
Yeah, so I have different cutoffs. In general, it's ideal if your BMI is definitely less than 40. It's ideal to have a BMI patient less than 30. If you're not sure what a BMI is, it's just Google it. There's a formula for it. It's your height based, or it's your weight based on your height, because 200 pounds looks different on a 5-footer than it does Shaquille O'Neal. So that's how we measure your BMI. So if your BMI is less than 30, you're a great candidate. If it's up to 35, your risk of recurrence starts sliding up. Generally, patients with a BMI over 40, I won't offer hernia surgery to them without losing some weight. Does that make sense? 35 is kind of a gray zone. 30 is ideal. 40 is too high for an elective repair.
But again, if there's a chance that you really need it and you feel above.
That's a good question. With any surgery we do, we just have to weigh the benefits versus the risk. And that, whenever somebody asks, should I have surgery or not, benefits versus the risk is the most simplest concept. So if you have no symptoms or only a few symptoms and your BMI is over 40, you probably shouldn't have surgery. The risk of it coming back, the risk of complications are going to outweigh any benefit that you have. Even if your BMI is over 40 and you got some gut stuck out there and it's on the point of dying and you're in lots of pain, I'm going to fix your hernia because your risks are very, very high. Yeah.
What about cancer survivor that had the mantle cell lymphoma, stem cell bone marrow transplant, Montgomery road cell. Still here.
Yeah, congratulations.
But I've got a hernia.
Okay.
I've got two of them. What are the risk of causing that cancer to reoccur?
Zero. Yeah, there's zero chance that a hernia, any sort of hernia repair would contribute to cancer coming back. or the hernia coming back. Is that what you're saying? If you've had chemotherapy recently or a bone marrow transplant recently, if your immune system's impaired, generally within 6 weeks to 6 to 8 weeks, somewhere around there, is what I would wait before doing anything. That's when that stuff works is the strongest. That's when you have the biggest impact. Same thing with my patients with colorectal cancer that get chemotherapy and radiation therapy. I wait 6 to 8 weeks until the effects of that have worn off, and then do their surgery, and they're kind of back to normal by then. So having a history of a bone marrow transplant or chemotherapy, as long as you're out, a few months away from having had all that, I think your risk of having a recurrence or a problem is pretty low. And if you said you had 2 or 3 hernias, that's another benefit of a minimally invasive repair. The 3 small poke holes fix all the hernias down there with no additional incisions. And one thing we just recently found out, or I found out, this is what I did my research paper and fellowship, is in that, how often do we see hernias on the other side that we weren't expecting? Well, when you do an open repair, you never look on the other side. You just don't make incisions looking for a hernia. So since we've started doing minimally invasive repairs, how often do we see a hernia that we didn't know about? And I found in my 300 patients, 20% of people had a hernia on the other side that we didn't know about. And with a minimally invasive approach, you can fix both with no additional incisions, save them a surgery down the road that they wouldn't have picked up on otherwise. I hope we've covered everything. If you have any questions, please feel free to ask. If you have a hernia or somebody that has a hernia or you're concerned about it, want to get it seen about, feel free to come see me or any of my partners. We all do hernias. If you have a complex hernia or something that they think I would best be dealt with or one of our partners would deal better with, we do pretty good at shifting things around and calling each other and say, hey, I got a patient that I think you would do better with. So just come see us if you think we can help you out.